So I entitled this talk, Dementia in Our Brains in Contemporary Aging Populations, because I knew that there would be a mixed audience and you will be at different stages of aging. And so I hope that I can pitch it for all of you, whatever your backgrounds. It is a skate through quite a lot of research, so forgive me if some of the slides are rather dense, but I will try to explain them and you can always tackle me afterwards. So we have aging populations around the world, and we have preconceptions about aging and what it is and how we might tackle it. But in fact, we can only know if we think about the population as basically going into the population and studying the population as it is, as Leon has said. So this is just some examples of people, of older people, of contemporary older people, and of course the participants in our different studies, the multiple generations who make up the aging population. That's 5 generations in one of our participant families, and it's fantastic having sort of multi-generational inclusion and excitement about research. So, but before I launch into it all, I wanted to do a little bit of a background into public health, for those of you that are not so familiar with public health approaches. So public health is the organised efforts of society for the improvement of health and well-being, and public health research is effectively all the research that underpins that effort. And so it can be primary care, it can be anthropology, it can be engineering, it can be a huge amount of a range of disciplines that contribute to our understanding of what it is that we as societies need to do to optimize our health and well-being throughout our lives. So it tackles areas like primary prevention, which is upstream prevention, secondary prevention, which is the early detection before manifest disease, so that's effectively screening, and tertiary prevention, which is traditionally what we provide within health and social care systems, and also end-of-life care. So it's about trying to understand the evidence and create the evidence and synthesize it, put it together for populations in order to try to do the best thing possible for current and future populations. So that's my take on public health research. Now this slide is taken from a Stevens and Raftery needs-based assessment text. And it really tries to highlight why it's quite difficult sometimes to do public health research and population research. Because there are many drivers going on in societies which, and again, Leon sort of alluded to this, that drive what we think we should be doing about health and what we think we should be doing about illnesses, and indeed what illness is. And what we have are different constituencies. So we have a demand being driven by contemporary media, medical influence, and social and educational influence. So basically the entire wraparound culture of what's happening to individuals. We have need, which is what's being addressed and there are treatments available for, and what is acceptable within the community in terms of culture and so on. And then we have supply, which is what we as societies put into our health and social care systems and our communities and so on. And these things are all slightly different. And in public health, we have to try to understand the tensions, because there are real tensions in these areas between demand and need. And need is usually defined as a healthcare problem for which there is something that can be provided which has evidence for it, rather than demand, which is a different thing. So these are areas that public health has to research. They all are amenable to research, and then try to create the jigsaw pieces that fit together to understand how best to do the right thing for society. So how do we generate the evidence that we think about in terms of dementia and aging brains? Well, this slide gives you just some of the myriad of disciplines and healthcare system localities in which research is generated. And if you're a person developing, say, memory problems here, you'll be out here in the population, But you might go and see your GP and then be referred to a memory service. And that might, depending on the country that you live in, it might be provided by the psychiatrists or the neurologists. You might go to a triage nurse, indeed, in the UK, and for some kinds of services. So different people get filtered at each stage. So you're filtered by your socio-cultural environment as to whether you seek help for a problem. And then in primary care, you're again filtered by the interaction with whichever professional you see in that setting, and then you go out into different services. So if you read research which comes from neurology about dementia, you will largely see research on people who have neurological symptoms, who are relatively fit, who are relatively young, have early onsets dementia. If you're seen in a psychiatry service, you may have psychiatric symptoms and maybe a little bit older. If you're seen in secondary care, you may have lots of different conditions and you may be quite sick and quite old. And institutional care, of course, you'll be a lot older and frailer, and end-of-life care similarly so. So the research coming out of these different areas and disciplines makes it look as though dementia is completely different. You get a completely different picture. And to understand what's happening in the whole population, you have to study the whole population. You can't really put it together from all of the different disciplines. Once you've got research on the whole population, then you can put all of those things into context and understand how it is that the neurologists see a different type of person from the psychiatrists and so on. So that's been a very driving force for my research in epidemiology. I'm sorry about that. I hope that's just something, I don't know why the blue bar's there. It's dropped down, I think, from higher up. So I'm going to describe some research and basically a fairly long trajectory of research. And it's the Medical Research Council Cognitive Function and Aging study as an example. And this study was multidisciplinary from the outset because it was quite clear that dementia needs many different types of people and types of brain to research it. And it's a research program that is run from many different universities, so we have collaborations across the country. And it's based across England and Wales, and it's in 6 sites. That's Newcastle, Liverpool, Gwynedd, Nottingham, Ely, and Oxford. And from those sites, we recruited people aged 65 and over, and this study was done in 1991. So I'm talking about people's brains a few decades ago. And we had 5 identical sites, 1 non-identical site. Liverpool is non-identical, and so you'll see results from different sites as we go through. We had rural and urban, we had institutions as well as community. So it was a true population base, and we had a reasonable response rate, which is very important in population-based research. And we followed people up as often as we could, and we did very extensive interviewing of those individuals, and we made dementia diagnoses in those populations using an algorithm. And that's very important because it means that it wasn't a clinical judgment. 20 years later, we repeated the study, and we went to Nottingham, Cambridgeshire, and Newcastle, and we re-recruited from the population. So we had a little bit of overlap with the original population, but largely it was completely fresh people aged 65 and over. That time we had a response rate which was much lower, and we can discuss that afterwards if you're interested, because response rates to this kind of study have gone down over time. It's not just in the UK, but it's a general phenomenon that response rates to these kinds of studies are reducing. So people flow through the study. So if you start at the top and then you flow through the study, and this is really just to show you that people get seen at different points and they have different intensities. So on the right-hand side, there's a different intensity of interviewing with more detailed interviews. And by the end here, we saw 3,000 people who, out of the original 13,000 in the 5 identical centres. I'm just describing that to give you a sense of the study, and it's a very complex exercise, of course, but what it allows us to do is it provides a platform from which we can study a lot more. So we can look at who gets dementia, what's the potential for risk reduction, might this be different across settings, and might this differ across time. So first of all, who gets dementia? one of the best measures of who gets dementia is looking at how populations change across time. So you see somebody at baseline, and from that flow chart, which I know you couldn't see the numbers, and I'm sorry, the colour's too intense. But from that flow chart, people flow through. And so at baseline, when you first see people, you can see whether they have dementia or not, and then you can see whether they develop dementia on the second occasion. So these data are derived from the follow-up data from people who had not got dementia at outset. And it shows you a rate, which is how much dementia is occurring in the population over time and in which age groups. And this shows you that there is this very steep rise in the incidence of dementia and that it's higher in women than men. And that's very standard across Western countries. So this is for the original CFAS study, for the one which was conducted in 1991 and followed up, for which I showed you the flow chart. The question that I was asked all the time by our Alzheimer's Society and folk who were working on the ground is, how long do people, once they get dementia, live? And at the time, it was very difficult to study it. So by following people up over time, you can look at survival from the point at which people meet a set of diagnostic criteria. And so what we found from doing the more prolonged follow-up was in CFAS that the median age at onset is 84, and the median age at death was 89. So we're talking about a condition which is predominantly occurring in the 9th decade. And most people who have dementia will be in that 9th decade. That's the biggest group, biggest numbers in populations in Western societies, at least in the UK. And survival in our study on a population basis was around 5 years for women and 4 for men. So this was quite useful data. But what we wanted to do was also provide more useful data in a fine-grained way. And we found that survival was heavily influenced according to the age group in which you had the onset. So the younger you are, obviously the longer that you survive, but also by the level of disability at the time of onset. So these are all trying to be helpful and useful, as it were, for the people on the ground, the person themselves when they have the diagnosis, but also the people around them and the care setting. So the longitudinal studies also allow you to look at risk, and I show this slide because it shows you the massive importance of age. It shows you that women are more likely to develop age-for-age dementia than men. It also shows you, though, that lower education is a higher risk factor, is a risk factor for increased incidence. And that self-reported health, sort of sense of general wellness, is a seriously strong risk factor. And so poor health, that is. And stroke is consistently Parkinson's disease as well, a very specific group for whom we should be able to do something, I think, on the medical front. And the general anaesthesia is one which I think is confounded by the fact that healthy older people access general anaesthesia for things like knee replacements and for this cohort and hip replacements and so on, and keep going and do rather well, because in general anaesthetics are thought to be have been shown to be more a risk. So we know that cognition itself is a risk factor for deterioration further, as it were. So the education shows you that in a way that you start at a lower rate of cognition and you decline faster. But we also know that having a lower cognition is associated with faster mortality. So it's not just a diagnostic entity. The relationship of cognition to mortality is very well established. So this is a study. A lot of the studies that I'm showing have been done by Australians who've come over to work with us. So Rachel Neal is from the QIMR in Brisbane, but she came over to us for a little while, and she did this analysis, which was survival with the mini-mental state. And what it shows you is that the mini-mental state's got a maximum of 30, that if you have the maximum, you've got the best survival, and this is controlled for age, of course. And if you can't even complete the mini-mental state, then you're very low, and along with your survival is low, along with those who have low mini-mental states. So this is a very consistent finding about low cognitive function. So cognition itself seems to be important to our well-being and our survival. So in this study, because we've got lots of tracking of people over time, we can look at how people move in and out of different states and what might influence those things. And what you can see here is an analysis by Riccardo Marioni, who looked at transitions between no impairment, slight impairment, moderate impairment, and severe impairment in the mini-mental state. And that's, it's basically moving around at 0 to 30. And what you can see here is the probability of moving backwards and forwards in different states. So it's the top people who have high education and have had occupational complexity and social and intellectual engagement. A lot of this work has been done in close collaboration with Michael Valenzuela from Sydney as well. And what you can see is that for people who are in the top of those, so they've got a highly engaged life, you might say, the probability of them moving from no impairment to slight impairment is half what it would be if they were in the lower group, in the lower third. And the probability of them recovering from that state is nearly 3 times what it would be if they were in the lower third. And you can see there aren't many, in moving around from slight impairment and moderate impairment is slightly different, but still the higher people are more likely to move up from moderate impairment to slight impairment. But I'd ask you to note this as well. From severe impairment to death, the people in that highly engaged group are more likely to die if they're in the severely impaired group. So this shows you a pattern, which is that the people who are, as it were, advantaged are having a better recovery from impairment, from the milder areas of impairment, but once they get into the severe impairment, they're more likely to die. So it's shortening the late life impairment, the terminal stages, if you like, the problems related to the end of life. So, and I'm showing you illustrations which are also very much present in others' research as well, but trying to just illustrate particular points. So how is this relevant to contemporary populations? So we've got a sort of sense of the way that the population is moving towards dementia and death. Well, we know that the risk factors that I showed earlier, we show some risk factors, others have shown different range of risk factors, but blood pressure is one which has been shown to be associated with late life dementia. And we know that we have trajectories throughout the life course of our blood pressures, and this is one way of tackling it. So this is not from my research or from my groups or our research, the collaborative research, it's from a group of cohorts that have tracked blood pressure within different life course ages, and it provides you with the distributions of the blood pressures over time. So you've got the blood pressure up here and the age here, and you've got different cohorts. And actually they're different birth cohorts, different generations, but they give you a good sense of the tracking of blood pressure across life. And they also give you the prevalence or the proportion of the population who are on antihypertensives in those populations. And you can see that it's a huge effect here and probably accounts for some of this drop in the oldest age groups. So we know that midlife hypertension is associated with later life dementia. And what we see here is this tracking is very important. But what we don't know is whether that is changing over time. And we need to understand how a person's tracking blood pressure relates to their dementia later in order to can change dementia in populations. So that's one risk factor. Vascular disease is another risk factor, which is so hypertension related to vascular disease. And coronary heart disease and stroke have been very strongly linked. I've already shown you the stroke findings from CFAS. And in the population, we're seeing changes that are really quite remarkable. A reduction in coronary heart disease mortality in Finland, and I would ask you to note that this scale here is logarithmic. So the drop in the age group here, 35 to 64 in eastern Finland, which comes from routine data, is really quite dramatic in both men and women. So there are very dramatic things happening to the risk factors for dementia in whole populations. And how do we understand those? Well, this is one analysis which has been done by Jusilati in Finland again, and it's trying to explain those drops. And what you can see here is if you put the things we know about, like smoking and blood pressure and cholesterol, and try to explain the findings, no one individual finding explains the drop. And indeed, in women, smoking, you'd expect heart disease, the coronary heart disease mortality to go up because smoking has gone up in those cohorts. And actually what's happened is this. So the risk factors, the reduction of risk factors doesn't fully explain the reduction in the coronary heart disease mortality. So there are really big things happening in our populations, which we need to understand. This is for men. And again, this is, if you put all the risk factors that they can measure together, that's about as much explanation as you get, but it's even lower than that. So the general consensus in the public health community is that it is a combination of risk factors that is contributing to this, about half, and about half is from better treatment. And there are other risk factors that are changing in the population as well, which may be underlying these particular changes. And here you can see, this is for England, you can see deaths from ischemic heart disease and stroke coming down in the same way as in Finland. And you can see that the blood pressure of the whole population is going down. And in parallel, we've got this reduction in salt in the population as well. So we've got smoking changing, salt in diet changing, and all sorts of things changing in the population, which are themselves associated with brain health. And brain size is changing. I don't know what the data are for Australia, but this actually is quite difficult to find empirical evidence on this. But we know that height is changing, and brain size, of course, will change because the skull size is associated with height. But this is something from the National Geographic, and certainly height has been increasing in many cultures and many countries around the world, and so it's very likely that brain size has been increasing. We certainly know that education has been changing around the world as well, not universally. And there is this thing called the Flynn effect, which is about IQ, and that has been going up in different successive generations. I don't know whether you think, actually, all kids now, the IQ's going down and people worry about it and so on, but there is this empirical evidence that IQ has been going up in successive generations, although it is just at the moment a little controversial about whether it's sort of plateaued or not. But so all those things have been associated with later life dementia and later life cognitive decline. So we need to really understand what's going on in the brain with aging and dementia in order to understand whether we think those things might have an influence on what's going on. Because the narrative about dementia is fairly simple. It's Alzheimer's disease mostly. Plaques and tangles. Solve that, you've solved the problem. I think many of you in the audience might think that that is the dominant narrative. Well, it's certainly the dominant narrative, but you might feel that that's the truth. But we really have to understand it. So we need to look at the nature of the neuropathology underlying the common dementias. We need to look at the relationship at different ages of the neuropathology. And we need to look at other factors as well. And we need to look at generations. We need to look at different people who've had different life experiences. So I'm going to move now into the brain donation findings. So we have rather unusually, and there aren't many of these studies around the world, we have brain donation linked to our population-based studies, and that's been going on since the mid-80s. So a marvellous nurse called Angela O'Sullivan pioneered the method of going to our participants and asking them whether they would consider thinking about donating their brains for medical research. This was in the 80s. And it predated all of the scandals that we had in the UK about organ and tissue removal after death. So our brain donation program actually was pretty well untouched by the massive concern that was going on in the UK at the time. So we have these marvellous donors whose pictures you've just seen as a part of an art exhibition. And we have, in CFAS, we have around 550 brains. And in the Cambridge City over 75 cohort, which I haven't described, but is very similar, and it's Cambridge City based, and it's 75 plus population that was started by Daniel O'Connor in the mid-80s, we have 260. And the results I show here are actually from the CC75C study, not from CFAS, although this is very similar. It's just really to provide variety for those people who were at my previous lectures. And what you can see here, down here, are important factors like age, and the features of Alzheimer's disease, and the features of vascular pathology in the brain. Basically, the things that a neuropathologist looks at when they do a standardized assessment of a brain. And here you can see the people who don't have dementia, and here you can see the people who have dementia. And here you can see the probability, sort of how important is the particular pathology in the expression of dementia in this population. And what you can see here is that, these factors are important. Plaques and tangles are important. They're all got very high levels as you come down, 4.6, 3.4, and so on. They're all importantly associated with dementia. They're all importantly associated with dementia. It's a great mixture of things that are happening in people's brains. And that's the really important factor that we need to take away from these studies. It's not one thing, it's a mixture of things. And what you can see, though, if you look at these, at the no dementias, is that these are not zeros, that the people who, the no dementias, have plenty of pathology. So it's very overlapping. It's a real, you're more likely to have dementia if you have the pathology, but you could have the pathology and not have dementia. It's not a 0-1 type of relationship. So we've looked at that in the CFAS study, trying to understand what proportion of the pathologies explains the dementia seen during life. And that's called attributable risk. And it's a very, very complicated analysis, and it's quite difficult to work out how to do it, because there's a lot of this pathology in the people who don't have dementia as well. But this is as good as we could do, and it's weighted back to the population, because the people who donate their brains are representative of the population, and we know how representative of the population they are. And we were trying to look at the things that are most important in contributing to expression of dementia during life. And here, what you can see is age is very important. And about 20% of the population attributable risk for that category of kind of risk is 20%. Brain weight is about 20%, so low brain weight, atrophy type thing. And for the Alzheimer type pathology, it's also around 20%. And for the vascular pathology, it's also around 20%. It's not quite the psychiatrist's rule of thirds, but it's kind of a rule of 20%. And the other pathologies, which are Lewy bodies and hippocampal atrophies, also sort of a bit lower, but 15% or so. And so what you can see there is that it's no one thing that's contributing to the dementia of this older population, of this usual dementia, common dementia, mixed factors. And having that many brains allowed us to look at the relationship of age and the expression of dementia and neuropathology. So putting all those things into one, you have to have a very large sample to be able to try to tease out that relationship. And what you can see from this slide is that atrophy in people who have dementia is consistently more common at each age. Here, this is the age at death, and this is the proportion with that pathology. And what you can see is age, there's a very consistent relationship between atrophy and the expression of dementia, whatever age you are. But if you look at neuritic plaques, which is a hallmark of Alzheimer's disease, you can see that the relationship is different at different ages. So that in the people without dementia, many, many people have got the pathology, but in the people who've got dementia and who are dying at these great ages, less people have got the pathology. So that it's not a stable relationship. So something else going on during life that is leading to the expression or the lack of expression of dementia. So we've also looked at the intermediate state, which is called mild cognitive impairment. And looking at somebody's cognitive state before they die takes you away from the need for the diagnosis, so you can look at the whole population there. And what Blossom Stefan found, who is also Australian and is now in Newcastle, that there was a linear relationship with a variety of things. So it's showing the same story of plaques, atrophy, infarcts, small vessel disease, but not with neuritic plaques and tangles. So it's not, these things are not pure. You've got in the group that come in through clinics, for those of you who have memory clinics, in the mild cognitive impairment, it'll be a whole mixture of pathologies that those individuals are presenting. The younger they are, the purer. So the older they are, the more complex. And this slide, which isn't the most recent delirium finding, shows that delirium is associated with different pathologies or from standard dementia. If you've had somebody who has had a history of delirium, which was done by Dan Davis going back, creating a measure for delirium within the CFAS study and working it out and looking at the brains of those. There are people, the blue lines are the people who had never had delirium, and the red lines are the ones who ever had delirium, and the black are all. And what you can see is the red dots are in different places from the blue dots. And so there does seem to be a different pattern of pathology for those people who had had delirium and have dementia. So what we're getting is a picture that is nothing like as simple as beta amyloid or tau even, or alpha-synuclein even, and dementia. It's much more complicated than that. So then we bring in the idea of compensation and reserve. So this is a concept that's coming along and gaining momentum now, and that is the idea that you might be born with a bigger brain, you have more synapses, you might have a higher IQ, you might have access to greater education and complexity, the occupational complexity and so on. So I've shown you the results during life of the transitions according to some of those things, but we've looked after death as well. And what we see after death is that for the same level of pathology, somebody who has had, or groups who have had higher education are less likely to express dementia when they die. Now, when we set this analysis up to look at it, because it gives you the level of press the wrong button. When you look at the levels of education here, along here, and this is just one indicative pathology, when we set this analysis up, I thought that we would see less pathology in the people who had greater advantage during life. I thought they'd have less vascular, probably less Alzheimer's because of less inflammation, all sorts of kind of more advantaged lives, healthier looking brains. But actually at death, their brains, the people's brains were pretty well the same. But they had not expressed the same amount of dementia during life. So it did look as though there was something else going on in the brain that allowed people to live their lives without expressing dementia before they died. So this brings me on to the changes in the population and cohort differences across time. And this is an analysis from the Cambridge City over 75 cohort. And this shows you just different birth periods. And it shows you the mini-mental state, which is a crude cognitive test, but it still works. We sort of understand how it works, and it's used around the world. And it shows you that this is control for age, of course, but it shows you that for each cohort coming through from different birth periods, that the mini-mental state has been gradually getting higher. So that's a bit like the Flynn effect, but we're seeing it within our own cohort. That's within a single cohort, rather than looking across cohorts sampled at different moments in time. So there's a clear importance of the life course. I hope I've shown that to you. Can dementia really be different in different generations? Well, we thought that was an interesting question to ask, and we managed to persuade, after about 5 attempts at getting a grant and raising the money, we managed to persuade the Medical Research Council to fund such a study, and that was the CFAS II study that I mentioned. And these were the sites that we repeated it in, as I mentioned. So new batches of 65 and over, completely new, fresh sampling, 2,500 in each centre, so 7,500 altogether. And there are also some sites in Wales, Gwynedd and Portneath, but I'm not reporting on those. And we repeated the same method. Now, the response rate, as I mentioned, was 56%. So we knew that there would be a sceptical audience for this research. And I was blinded to the results whilst we went through the analyses, because we had to treat the first, I was one of the only investigators who was around in the original study, had to do everything the same as the first time round. And so I really did not think there would be a difference in the prevalence of dementia. And we needed to make sure that it wasn't just because of a lower response rate. So we did sensitivity analyses, which is testing it, basically trying to say, if the refusers, if the people who didn't take part were like this, what would it look like? What's the most extreme we could do in order to make it look different? And so we really we gold-plated this analysis because we knew it was so important. And that was going on with me not knowing what the results were. Because the biostatisticians were holding up. Fiona Matthews was the lead biostatistician for the MRC Biostatistics unit. And when she did unveil the results to me, I said, we have to break them again. We have to try. We have to try to break these results because no one's going to believe this. We couldn't break them, basically. So what we showed was that age for age, dementia over 2 decades has gone down by over 20%. And that means that the estimated numbers of people with dementia in the UK remained the same over a 20-year period. And I'll show you some other ones in a moment. The incidence data are like this. So that's the 2-year follow-up. And that also had gone down. We had to completely reanalyze the original study, so make it completely comparable. Again, sensitivity analyses to break the results. And it was also a 20% reduction. Now, in the prevalence drop that we observed, it was the same for men and women. But in the incidence drop, it was entirely driven by a 40% drop in men and pretty stable in women. So clearly we need to understand that more, because that's the occurrence of new cases as opposed to those that are there in the population. So these are really profoundly important results, because it suggests that dementia is changing in populations, and it may be that underlying neuropathology that is changing, the cognitive reserve, the compensation, and the actual pathologies themselves may be different in contemporary populations compared to 20 years ago. So it received an enormous amount of media attention at the time, those studies, when they came out. But the dominant narrative is still there's a tsunami of dementia on its way around the world. And of course, both things are probably true. Partly that's to do with, in lower middle income countries, many of the factors that may have led to this reduction are going in different directions, so that you could try to model what's going to happen in populations on the basis of the profile of risk factors. So although it looks really good in England and Wales, it isn't great, because what we found was a significant variation across site, and that was explained by social deprivation. So what we have shown is that people who are socially deprived effectively live shorter lives at higher risk of dementia. And that's something that we have to do something about as researchers and public health folk, because it is probably the accumulation of life course exposures that is leading to that outcome. So a person in Newcastle in the UK, lives years shorter than somebody from the south, and somebody who's 65 will look very different from an 80-year-old or a 90-year-old highly educated person who's still on their bike in Cambridge. So we have very, very different populations in the UK, as do you in Australia. This slide shows you how variable prevalence is across the country by gender. taking into account the social deprivation and the age structure of the population. So you can see that localities need to take these different factors into account in order to estimate how much service to provide for those communities. And the nature of the dementia may be rather different in different places, but we can't answer that particular question. So I've given you these results, and I mentioned at the beginning that it was really important that we kept our diagnostic methods steady. Well, over the period of the last 30 years, there's dealing with dementia diagnosis is a little bit like trying to do something with sand, because it's changing, sand and water, because it's shifting all the time. The diagnostic boundaries of dementia are changing, so that things that previously might not have been called dementia are now being called dementia. Mild cognitive impairment, and there's lots of different ways of approaching diagnosis. But I wanted to give you, so I'm not going to go into that in detail, but I wanted to give you an example of why it's so important for epidemiology. Because we are trying to understand what the burden to the population is, but the burden to society, and what can we do to mitigate that burden and make it something positive. This is a PhD student who did a systematic review of Chinese studies of prevalence, because there's lots of studies of Chinese dementia in China over time, increasing in number, as you can see. The ones that, so before 1990 and then up to 2005 to 2012. And the PhD student put them all together, and if you look at them in a crude sort of way and don't take methodology into account, it looks like dementia is doing this. But if you look at the ways that the studies were done, the sampling and so on and so on, and the diagnostic method, because the diagnostic methods have changed over time in these Chinese studies as well, and you correct for those changes in sufficient, where there's sort of overlapping periods, what you see is that there is a non-significant increase. So that this shows you that the diagnostic method can make you seem as though you've got an enormous problem or a manageable problem. But the only way you can tell whether a population is changing is by holding the diagnostic method steady. So when the WHO introduced new cut points for the definition of diabetes, overnight, millions and millions of people, more people, had diabetes. That doesn't mean that millions and millions more people are going to have the same complication rates that the previous lot had. So we really need to understand what we're doing when we're changing the diagnostic criteria. And that's why we had to keep our diagnostic methods steady in order to look at changes across time in the UK. Other people have been looking at changes across time as well. And these are the studies that are comparable. And these are prevalence comparisons across the world. And again, this is Yutsu's work, who's now at Exeter. And at the top, there's Gothenburg. You may not be able to see the places exactly, but they're time periods and comparisons within each block. And the top lot are lots of Swedish studies. And then there's a Spanish study in Zaragoza. And then there's CFAS, which is here. And then there's Hisayama, which is Japan, down here. Now, anything that's under 1 is where it's going down. And anything around 1 and with the lines over it means that it's a bit difficult to tell whether it's changing or not. So some of these going up, some of them going down. Doesn't really show a tremendous pattern, but there's a little bit of a hint here with Zaragoza and CFAS, and there are some here which are apparently lower across time. The French studies that have looked across time, Bordeaux, have been able to directly compare clinical diagnosis and algorithmic diagnosis to see what the shift across time periods might be in diagnostic practice. And so that's inside this red box. And what you can see here is when you have the clinical diagnostic method, there's no change. There's nothing. It's not below. But if you look at the algorithmic method, you get a significant reduction in women there. Men are much the same, but it carries a significant reduction for the population as a whole. So there's something changing in the population if you do hold the method steady across time in different cohorts which have been recruited and studied in much the same ways. So this also shows you the Framingham study. This introduces an American study which shows a similar reduction. And the health and retirement study from the US also shows a reduction of around a quarter. So there's more evidence every day, well, every month or so, there's a new study coming online which suggests that prevalence is indeed going down. It's just CFAS was sort of a bit ahead of the trend. What about incidence studies? That is the new occurrence of dementia over time. Now, in this one, you can see a really clear pattern from the studies around the world of a reduction in incidence. And of course, that's really moving forward because it's a forward occurrence of dementia, new dementia. So we're beginning to see a much more consistent pattern of reduction over time. We've tried to, or we haven't in CFAS because we couldn't, but in other studies they've tried to explain this difference, a bit like I showed you the studies from Finland, where there's been an attempt to understand the changes over time in coronary heart disease, that the different studies, like Bordeaux study, the French study, the US study, and a study from the Netherlands, have tried to explain, using the risk factors that they've measured in the population, how much it accounts for, how much of the drop does this account for. And you have the risk protective factors here, and then the methods of the ways that they've gone about trying to analyze it. And they haven't really, so the bottom line is that they haven't really been able to fully explain the change. Now that might be because the risk factors are not well enough measured, but it might also mean that there are other factors that we don't understand that have been changing across time. But all of these have changed very dramatically across time, some in positive directions and some in negative directions. So we can't yet explain these drops that we're observing, and it really needs very profound research to understand what's changing in the individuals who are getting dementia now to see whether it's different from in the past. And one of the things that we think we really need to pay more attention to is not so much those risk factors like that, but thinking about the life course experiences of the individuals who's passing into the older age groups now. And this slide simply gives you the life expectancy at a particular period for a particular country. So the countries that have got the studies that have prevalence or incidence studies, Spain, Sweden, Netherlands, UK, France, Japan, Nigeria, US, and US white, or US general and US black populations. And this is life expectancy of birth for those populations. And you can see that there's actually quite considerable variation in the different populations. And unless we understand which cohort people are in and what's happened throughout their life course, because those massive drops are during huge events, and everybody's life at every age will change as a result of those things. So there'll be differences in all sorts of exposures as a result of those things happening in populations, that we need to know who's passing through which stage during their lives and how that might influence their risk then later when they reach older age. So trying to integrate these findings with the public health perspective for contemporary populations, I hope I've shown you that populations change over time, and that dementia and cognition are changing as well. Brains are changing. Cognition isn't going to change in a vacuum. It's got to have a brain to be in, as it were. But we don't know exactly how. We all do die, and there is a period of decline beforehand, and the education seems to push that, make that a little bit shorter. We know that population level action, societal or legislative, is more cost effective, and I haven't shown you these data, than individually based interventions. And it does seem that the things that might be leading to this reduction in dementia in whole populations are more at the population level than they are at the individual level. We also know that prevention trials in individuals, there haven't been all that many of them, have limited evidence to date, but there is a great deal of interest in doing more, and they've only been done over relatively short time periods. So we've actually got limited evidence, direct evidence about prevention and risk reduction, but because of our findings, it's attracting a lot more attention. But there is very compelling evidence for upstream prevention of non-communicable diseases like diabetes and heart disease and stroke. And the action is clear, and a lot of that action is at population level as well as some at individual level, as I've shown in the Finnish data. I'd like to highlight that social deprivation really clusters risk factors. So there are people in the population who are at severe disadvantage in so many ways, and we really need to try to work out how to address that better than we do at present. And we need to think about the balance, we need to, of investment into different types of activity, including the different types of research. And we probably aren't ready at all to do individual screening for dementia. The evidence base just isn't there. We have a lot more compelling and parallel evidence for good action elsewhere. And we need a life course approach to optimize our brain aging at every age, starting with the pregnant mums and their fathers and their parents. And so risk reduction is a really key thing, I think, and we're going to see much more about it in the future, as well as needing to clearly support those who have dementia, because it's not going to go away and is unlikely. It's always going to be, it seems to me, that it's always going to be with us, so we always have to have that balance of investment for upstream prevention, possibly a bit of early detection when we have much better evidence than we do now, and support for those people who have dementia and appropriate end of life as well. So, all in one slide. That's just the integrative slide, and I'd like to thank you for your attention. I've just put my credit slides up in as well. This is the slide of Margaret Whitehead, who's a fantastic public health person who's created the integrated model of how we need to work as societies, not just for dementia, but for health as a whole and well-being. And I'd like to acknowledge all my masses of collaborators. Of course, there's thousands of people who have contributed to the research results that I've shown you today, from many institutions and from many funders as well. Thank you.